I'm very privileged to introduce Dr. Aliya Ladha, who's our speaker for today. Dr. Aliya Ladha is a board-certified OBGYN physician with Virginia Hospital Center in Arlington, Virginia. She has been in practice for over 10 years, treating women in general obstetrics and gynecology. And recently, she also became Menopause Society Certified Practitioner. We're very excited for her to present on this very needed topic for our Jamaat, the menopause journey. And before we start the presentation, I'm also going to set some ground rules. So everyone is muted, but when we come towards the end of the session, we are going to unmute people and let them ask questions if they need to. But as your questions come, please put it on the chat so that we can address them toward the end. And other than that, if you think that you want to post some question confidentially, you're welcome to send it to me, Sana Somani, or AKHB Northeast on the private chat feature in Zoom. So we'll be happy to answer that. And in the end, we will have a survey. I'd really appreciate if people can stay on for 2 more extra minutes at the end just to answer that survey so that we can continue to bring sessions that are relevant and knowledgeable for the Jamaat. And with that, I'm going to give it to Dr. Ladha. Thank you.
Thank you so much, Sana, for that gracious introduction. I am so excited to be giving this webinar today. I hope it is fruitful for everyone. I'm going to be speaking for about 45 minutes or so. I want to make sure that we have ample time for discussion and questions afterwards. Okay. As Sana mentioned, I'm a full spectrum OBGYN physician. And I wanted to mention specifically that we don't just deliver babies. A lot of people don't know what an OBGYN does. And so I can see patients as young as 16 years old, but also as old as 80. We discuss birth control, heavy menstrual periods, fibroids, endometriosis. I perform gynecologic surgery, but I'm also involved in preventative care, screening for cancer. So basically, as an OBGYN, we manage any problems related to the female organs. Sana mentioned that I'm a Menopause Society Certified Practitioner. So this entails additional training specific to menopause, but also taking an examination. And just a little bit, my background's in kinesiology. I also did a master's in exercise and cancer research. So I do focus a little bit about exercise in my talk today. So at the end of this talk, hopefully you'll be able to understand some of the hormonal changes that occur during the menopause transition, gain some knowledge about some of the symptoms experienced, and also learn about the health impacts that this period has now, but also in the future of your health. Learn how to manage some of your symptoms and overall improve your health at midlife, but also beyond. So why don't we talk about menopause? Well, for one, there is a lack of concern for women suffering. Many women are turned away regarding their symptoms, and they're just told, well, just deal with it. It's normal. Aging has actually not been looked upon by our society very positively. We're a youth-obsessed culture. There's some shame and some stigma behind going through or getting old or going through menopause. There's also a lack of accurate information. We have to tease out misinformation versus biased information. In today's age of the internet, social media, influencers, there's a lot of opinion out there versus actual fact and research. And we know that the majority of research, scientific research, is done in men. This is changing or has been changing. There's also a fear of aging, hormones, cancer, death overall. And there's needs for more provider education. OBGYN residency, at least over 10 years ago, it didn't spend any time or training on menopause, and hopefully this has changed. Why we need to talk about menopause is because more than 60 million women in the US right now are over the age of 50. And more than 20 million are in their 40s, already experiencing some of these menopause symptoms. Up to 85% of women experience symptoms, and more than 60% of women are now living until the age of 80. So that means we spend up to 40% of our lives after menopause. That equals 30 years for some women. We also need to talk about menopause because it affects everything. It affects our sleep, our mood, our relationships, our overall quality of life, our ability to work. And midlife women are often at the peak of their careers, but they're also involved in their family. The decisions we make right now about our health in the midlife can actually set the course for the rest of our lives. So in order for us to talk about menopause, we actually first need to really understand what happens in a normal woman's menstrual cycle. So textbook-wise, a normal woman's cycle is about 28 to 32 days, and two main female hormones are involved, estrogen and progesterone. So in this graph, it's very, very complicated, but all I want you to look at is the blue line, that is estrogen, and then the green line, that is progesterone. So if you see sort of the two big hoops also covering them, those are the main areas that you want to look at. So estrogen, I call the lawnmower, or sorry, estrogen I call the fertilizer. It makes the lining on the inside of the uterus grow. And once estrogen gets high enough, it signals the brain to tell the ovary to pop off an egg. That's called ovulation, and that's that middle blue line there. Once ovulation occurs, estrogen goes down, and then progesterone goes up. Progesterone, I call the lawnmower, that cuts the grass or that makes your lining shed. So that's the menstrual cycle. So this happens every single month in a very cyclical, rhythmic fashion. So menopause then is the just normal natural event that ends the woman's menstrual cycle from the loss of hormones that are produced by the ovary. And this is just due to aging. Some terms that I want to go over. So perimenopause and the menopause transition can be used interchangeably, and they both mean the exact same thing. It's basically the beginning of the menstrual or the hormonal changes up to 12 months after your last period. Some other terms, menopause is literally the day of the final period, but nobody ever knows when that day is going to be because it's actually 12 months later that we call you menopausal. So this is from when you're 1 year away from that final bleeding. And then postmenopause is all the years after the final menstrual period. So this timeline sort of gives us everything. So perimenopause is the beginning of those hormonal menstrual changes, and that can begin around 46, 47. This graph says 48. Then you have the final period, and then 12 months later, you are considered menopause. So the average age of menopause is about 51 to 52. Now, symptoms can actually peak until about a year after that final menstrual period, and then they can last for about 4 to 7 years after. So this is because of the winding down of the estrogen and progesterone production by the ovaries. So just like there are hormonal changes that lead up to the very first period, like in puberty, there are hormonal changes that lead up to the last period. And this time period is known as the menopause transition or perimenopause. So this graph just further illustrates, the changes in the cycle. So on the left side, we have premenopause, or what's really called the reproductive years, right? So very predictable. This is the cycles that I was telling about. It's very rhythmic pattern, creating that 28 to 32 day menstrual cycle. Then you go to perimenopause or the menopause transition. This is where hormonal patterns change due to the fluctuating levels of estrogen and progesterone. And you can see it's very chaotic. It's not just like a gradual decline, but it's more like a hormonal roller coaster with sudden surges and drops. And this is where we have symptoms like the mood swings, the irregular periods. And then you can see postmenopause, where it's very, very steady state. This is when the ovaries have completely shut down. They're no longer producing follicles, no more estrogen and progesterone. And so now the estrogen that's being produced is very minimal, and actually it's by either the adrenal glands or the fatty tissue. So what impacts the age of menopause? Several factors. Genetics is the first one. So the age that your mother went through menopause is a really good indicator of how old you will go through menopause, unless she's had a hysterectomy. So I want everybody, if they can, to go and ask their moms what age that she went through menopause. Race, Asian women actually enter menopause later than white women, and Black women tend to enter menopause about a year after that. The age of first menstrual period. So this is also related to the lifetime exposure to estrogen. So the younger you are, if you had your period less than 11 years old, your first period, then you're likely to have earlier menopause. Pregnancies and breastfeeding are actually protective. And the older you were with your first pregnancy means likely to be later in menopause. If you've not had any pregnancies, it's possible that you could have an earlier menopause. Underweight or low BMI, earlier menopause, whereas with higher BMI and obesity, you see later menopause. Cigarette smoking, if you are engaged in any kind of smoking, actually, it's earlier menopause. And if you've had a removal of an ovary, which equals decreased ovarian function, it's likely to cause earlier menopause. So a few more terms. These are all instances of early menopause and when you actually need estrogen treatment, which of course treatment I'll talk about a little bit later. And estrogen has benefits. It shows that women who have their ovaries until at least the age of 60 live longer, they have better heart health, their bones are stronger, and there's actually a decreased risk of dementia or memory loss. So primary ovarian insufficiency is when a woman has her final period before age 40. Premature menopause is when that final period is between the age of 40 and 45. And then surgical menopause, if the ovaries are removed before the natural transition, which remember I said with that timeline, average age of menopause is about 51. So before I mentioned, menopause causes a natural decline in the estrogen levels. So this results in a wide variety of symptoms because estrogen receptors are found on many parts of the body. It's really difficult sometimes to know whether or not some of the symptoms or experiences are just due to natural aging or if it's actually a decline in estrogen. What we do know also happens during this time is that women notice an increase in insulin resistance as well as increased cholesterol, and that's due to menopause. So this then in turn results in an increased risk of diabetes as well as heart disease. So these are all of the organs that have estrogen receptors: the brain, the genitourinary tract, which is the bladder and the vagina, the heart, liver, the skeleton, and skin and hair. So that means that menopause is associated with many symptoms because of where these estrogen receptors are on the female body. So some of the major symptoms: hot flushes, night sweats, sleep problems, mood changes, dementia, urinary symptoms, vaginal pain or dryness, heart disease, cholesterol changes, osteoporosis, skin and hair loss, and that's just to name a few. So the first thing that women start to see in the menopause transition is a change in bleeding patterns. So over time, menstruation starts to space out and you start to skip periods. We believe that when women start skipping periods, we think that they're about 1 to 3 years away from their final period. Skipped periods can be followed by heavier bleeding. At this time, there's a significant decrease in fertility or the ability to become pregnant, but it still is a possibility. So that needs to be considered. Continuous bleeding needs to be ruled out. The most concerning thing would be uterine cancer, so further evaluation is needed. Okay, so menopause symptoms. The most common menopause symptoms are what's called the vasomotor symptoms, which are hot flushes and night sweats. About 75% of perimenopausal women actually report having vasomotor symptoms. So this is because in menopause or during that transition, the temperature zone in the brain for body temperature becomes very narrow. And it's more common in actually women who suffer from premenstrual symptoms, in women who are smokers, as well as women who are obese. A vasomotor symptom or a hot flush or a night sweat is a sudden intense heat in the upper body, the face, the neck, and the chest. It can last anywhere from 30 seconds all the way up to 5 minutes. And it can also include sweating, chills, anxiety, and palpitations. The other most common symptom is what's called the genitourinary syndrome of menopause. And so this is, again, due to the declining estrogen levels. So the loss of estrogen in the vagina causes thinning or fusion of the labia majora with the labia minora. There can be narrowing of the vaginal canal and the opening. The vaginal tissue tends to become dry and tight. So if you think about like in winter times when we wash our hands so much, we get cracks on our knuckles. And that tends to bleed. Well, that actually can happen in the vaginal tissue. And then in turn, this can result in pain with intercourse. The pH balance also increases, making it more prone to infections. And as I mentioned, dryness, itching, and loss of elasticity. So in the bladder, as well as the urethra, there can be burning and pain with peeing. You can see urgency or frequency symptoms, and some women are at risk for recurrent urinary tract infections. And unfortunately, this becomes worse as time goes on because of the lack of estrogen. So other more common menopausal symptoms, and I'll discuss each of these in further detail in the next slides. So sleep disturbances, mood and mental activity changes, muscle and joint pain, skin and hair changes, as well as weight gain. So sleep disturbances. So this can be due to night sweats. I have women patients that come and tell me that they wake up several times a night. They're drenched in their, pajamas. But aging naturally also causes changes in sleep. So other things that we have to rule out is sleep apnea. This is a sleep disorder that causes breathing to start and stop suddenly, and this can get worse with aging as well as obesity. Sleep disturbances are associated with effects on mood, worsening depression. Imagine day in and day out, you aren't sleeping well, you're restless. Overall, your quality of life is going to be impacted negatively. Other things that should be ruled out, anxiety and stress levels that can affect sleep, as well as restless leg syndrome. So some sleep hygiene techniques. Now, this seems like common sense, but many people don't actually practice these techniques, and this can actually help you sleep better. So make sure you're in a cool and dark, quiet room. Sleep when you're tired, so avoid watching the clock. So if you are just watching the clock, get out of bed, read a book, and then come back into bed when you're tired. Don't watch TV or use screens in your bed, so your phone, your iPad. The blue light is very stimulating to the brain. It makes it difficult to rest and go to sleep. Wear light sleepwear. Avoid heavy food or exercise within 3 hours of bedtime. Avoid alcohol, caffeine, and nicotine. These are all stimulants. And try maybe a relaxation technique like a warm bath right before bedtime or meditation. And be sure to keep regular sleep and wake cycles even on the weekends. So mood changes. So just like hormonal fluctuations occur during puberty and menstrual cycles, during postpartum, this occurs during the menopause transition, and that can cause mood disorders. So depression, anxiety, irritability, decreased motivation, decreased enjoyment in activities. So some risk factors for mood disorders, if there's already a personal history of depression or prior, if a woman is overall poor physical health, if she already has existing hot flushes or night sweats, she's at higher risk of having mood disorders. If she's part of the sandwich generation, so taking care of really young children, but also aging parents, changes into her own health or her partner's health, and other stressors like the death of a parent, changes in marital status, or other transitions like empty nest, the kids leaving the home. Some other symptoms, cognitive changes. So memory can decline during the menopause transition. There can be forgetfulness, word recall, concentration can be affected. I have a lot of women come to tell me that they have brain fog. So problem solving, word recall, the ability to retrieve information, like the word is on the tip of my tongue and I can't remember it. Or many of us like go into a room and then they forget what you're doing. I don't know if that's mom brain or really related to menopause, but that can occur. I had a patient that told me that she couldn't make decisions really quickly and she couldn't crunch numbers as fast as before. So aging, again, is the biggest contributor of this, but it can also be related to menopause. Definitely surgical menopause, which I mentioned before, so removal of the ovaries, if that occurs, especially at a young age, so less than 45, a woman is at higher risk of having cognitive impairment and risk of dementia. Muscle and joint pain. More than 50% of women have reported joint pain during the menopause transition. Symptoms do get worse with obesity and decreased activity or exercise. And again, aging naturally causes osteoarthritis. But we do know from one of those pictures, remember there were estrogen receptors on the skeleton. So it does have positive effects on cartilage and bone. So during menopause, there is a loss of estrogen causing bone loss. This can mean a higher risk of osteoporosis, which is weak and brittle bones. And so there's a higher risk for fractures. So I recommend that all women have a bone density. It's called a DEXA scan at the age of 65 or younger if you're at higher risk. And this can be discussed with your physician, but also vitamin D, calcium supplementation. And I'll talk about supplements a little bit later. But most importantly is going to be weight-bearing exercises. Some other symptoms, hair and skin changes. So we see hair loss and thinning, reduced hair growth on the scalp. This is female pattern hair loss. Increased shedding, but also unwanted hair growth, like on the facial areas. We also see changes in the skin, like dryness, itching, wrinkles or sagging, poor wound healing, as well as pigmentation changes. But it's again important to remember that other factors can impact this. Thyroid disease, genetics, again, aging, and other medications that a patient is on, as well as stress. We also see a 30% decline in collagen levels in the first 5 years of menopause. Important to consider where you live, like is there a lot of sunlight? Is there UV exposure? Are you using sunscreen? Are you a smoker? Alcohol? Is there a poor diet? So all of this also impacts hair and skin changes. And just to note the prescription there, this is the only FDA-approved medication for hair loss. It is Rogaine. Some women do use collagen and biotin supplements. So weight gain. So this is a big one. I have a lot of patients coming to me because of weight gain. So the SWAN study is the study of women's health across the nation. And it showed that women gained an average of 1.5 pounds per year during the menopause transition. So remember the years that it takes for the ovaries to completely shut down. Now, weight gain is mostly due to aging as well as lifestyle. Both men and women gain weight between the ages of 40 and 60, but it's shown that women do gain more weight, and it's likely because of menopause. This is also multifactorial. So as we age, if we're more sedentary, this causes a decrease in metabolism, a decrease in energy expenditure. And if we have a poor diet, we're increasing our caloric intake. So all of this impacts everything. So what we know does change during menopause specifically is body shape or body composition. So women, as they go through menopause, will lose some of their lean muscle mass. Before menopause, women gain weight around their hips. This is called subcutaneous fat. This is the fat underneath the skin. But as you go through the menopause transition, weight gain actually shifts to the waist. This is the visceral fat. This is the fat that wraps around your organs. And this is what's linked to heart disease as well as diabetes. And this is why cardiovascular risk in women starts to increase after menopause. So this graph here shows cholesterol change with age. Women are in the pink, men are in the blue line. And as you can see, women after the age of 50 start to see an increase in their overall cholesterol levels, whereas men actually start to drop. As a result, this can impact the risk for diabetes, I mentioned already, heart disease, breast cancer, liver disease. So now what? So you need to see your primary care practitioner every year for your prevention visit. Some women actually stop seeing their OBGYN after having babies, but it's really important to continue seeing your GYN every year. I had a patient just last week that said she's had really heavy bleeding and cycles, severe pain and cramping for as long as she can remember. And she didn't know that until she talked to her friends that this was not normal. So please continue to see your GYN even after your pregnancies. We need to rule out thyroid disease, sleep apnea. We need to check cholesterol levels, screen for diabetes. You need to work on quitting smoking. And the most important things are diet and exercise. So really focusing in on the Mediterranean diet and having a good health foundation with exercise. So a Mediterranean diet is centered around fruits and vegetables, whole grains, beans, nuts, legumes, lean protein from fish and chicken, so limiting red meat, and then good healthy fats from olive oil, avocados, as well as limiting added sugar. Exercise. So we can't deny the impact that exercise has on all the domains actually that menopause touches. It impacts depression, sleep, keeping your bones and joints strong, weight gain. It can decrease your risk of diabetes, heart disease, high cholesterol. Probably the only thing exercise can't help with is going to be hair loss and the genitourinary symptoms. If exercise was a drug, it's literally the one prescription that I would be giving to everybody. So when we talk about exercise at this stage of life, it's really important to do weight-bearing exercise, weights, resistance, calisthenics, and core. I had a patient, just to digress a bit, I had a patient probably about a month ago now. She came to me just for her annual well woman visit. 72-year-old, and she said that she used to work in DC, really hectic job, like 60 hours a week, had no time for anything but her, her work. And she finally retired at 68. And so now she tells me that she plays 2 hours of pickleball every day. She does yoga, Pilates. She, I guess, signed up for a Fairfax senior center. And so if you travel, you can even get online yoga classes. So she's going on and on about how much exercise she's doing. And she tells me, she's like, I have more energy now at 72 than I did when I was 50. And she's going on and telling all her friends about exercise. And I said, you're doing my job for me. But I hope I'm her when I'm 73 years old, because she's literally the prime example of what vitality means because of diet and exercise. So let's talk about weight loss. So we need to target visceral fat. So visceral fat, remember I mentioned this is the fat that's in the waist around the organs. So increasing your fiber, increase to about 20 grams per day. And you don't need supplements to do this. It's very easy to actually get fiber in your diet. If you make a smoothie, add a tablespoon of flaxseed and chia seeds, and you already have 10 grams of fiber right there. Eating well is hard work. It takes time, it takes meal prep, but you can do it. Decrease your sugar. So no more than 25 grams, which is equal to 6 teaspoons of added sugar. So I'm not talking about the natural sugar that is in fruits or vegetables. This is the sweets, like the cookies and the added sugar in our chai and our coffee. So really limit that to 6 teaspoons per day. And then again, exercise. So the American Heart Association recommends 150 minutes per week. But if you can break it down per day, or even like 10 minutes in the morning and 10 minutes in the afternoon, and I'm not just talking about like, a stroll down the street, like get your arms pumping, your heart's pumping, you're a little bit out of breath when you're walking. That's when you know that you're really making an impact. And increasing your muscle mass. So I mentioned this before, really focusing in on strength and resistance training, but also increasing your protein. So recommendations, you can, there's different things where you read it, but I would say a minimum of 7.7 grams per kilogram of body weight per day. So for example, a woman who's 135 pounds needs 95 grams of protein per day. That's a lot of protein. None of us are eating enough. So now menopause therapy, unfortunately, will not help with weight loss. There were several randomized control trials, which is the gold standard in research, where it combines a drug with a placebo or no drug. And there were two trials that were done, the Replenish trial and the KEEP study. The Replenish trial looked at women 40 to 65 years old with combined estrogen and progesterone treatment and compared it to no drug or placebo. And unfortunately, they saw no change in weight at 1 year. In the KEEP study, they looked at women 42 to, 42 to 58 years old, and they had 3 arms in their study. So they looked at combined oral treatment versus transdermal, which is on the skin, which I will talk about shortly, versus no drug. And again, they also saw no change in BMI after 4 years. So let's talk about treatment. Menopause hormone therapy is indicated for the 3 areas of early or premature menopause I talked about earlier. So primary ovarian insufficiency, premature, as well as surgical menopause. It's also indicated for the genitourinary syndrome and the vasomotor symptoms, as well as the prevention of osteoporosis, especially if you're at high risk. Okay, let's talk about genitourinary syndrome first. So this typically prescribe or just tell women initially coconut oil, Vaseline, Aquaphor. Vaginal lubricants can be used during sexual activity. There's a lot of non-hormonal vaginal moisturizers out there over the counter. These are some of the brand names. Replens is usually one of them that I mentioned. And these are intended for use like several times weekly, just to reduce the dryness. Vaginal estrogen is the most effective. It restores vaginal pH balance. It helps thicken the vaginal tissue. It increases secretions. There's various forms that we prescribe. It's in a vaginal cream, a tablet, a suppository, as well as a vaginal ring. Like it's a ring that's made out of silicone, and you insert it every 3 months. It's important to note that the improvement in the vaginal tissue takes time. So you may not see improvement for even like 6 to 8 weeks, because the vaginal estrogen has to really penetrate deep into the vaginal tissue and the vaginal mucosa and bring back that elasticity. It is very safe and effective. It can be used in women with breast cancer because it is very localized to the vagina. So it's very safe, and treatment is essentially lifelong, or for however long you're having symptoms. Now, treatment of vasomotor symptoms. So it's very important to understand that while we have medications that can improve symptoms, medications can also only do so much. So there is some evidence to show that cognitive behavioral therapy has actually been found to be beneficial. Over-the-counter products like black coal hash, evening primrose oil, and soy-based supplements are not really likely to reduce symptoms. They haven't been studied by the FDA for safety and efficacy, so we generally don't recommend them. Generally, treatment is either hormone therapy or non-hormone therapy. So hormone therapy, it's usually a combined estrogen and progesterone treatment. Progesterone protects against uterine cancer because one of the risks of estrogen is uterine hyperplasia or cancer. But if a woman has had a hysterectomy, then she doesn't need it and she can take estrogen alone. Treatment is typically started in women less than 60 years old or within 10 years of the final menstrual period. There was a recent article in the January 2025 issue of the Lancet, Diabetes and Endocrinology, suggesting that hormone therapy can actually be taken or started later in life, and it may not actually carry the risks that I'm going to further talk about, but this is all ongoing research. So for now, this is the evidence-based treatment option. So the goal for estrogen treatment is for the lowest dose for the shortest duration of time. Our goal is to decrease the number of hot flushes per day, the number of night sweats at night, trying to help you basically sleep through the night so that you're not going through so many symptoms. It takes about 6 to 8 weeks for improvement in symptoms, and we adjust your dosage based on clinical symptoms, not hormone testing. And I really want to emphasize this point. We don't endorse any blood, saliva, or urine hormone testing. If you go to someone and they recommend this, this is a money-making scam. There are several wellness clinics, even locally here, that will charge like $400 to $500 for a consultation. They'll charge for blood work. Remember that hormonal roller coaster that I talked about initially? Your hormones can actually be normal at one time point, and it's going through like the up and down. So hypothetically, if I test your hormone levels and they're normal, that doesn't tell me, that you're not in menopause. Your symptoms tell me that you're in menopause transition. So if that's the case and your overall quality of life is deteriorating, I'm still going to treat you. I'm not going to do any of this testing. So hormone therapy is estrogen and progesterone. So formulations, the first one that we recommend generally is transdermal. So this is applied to the skin, and it basically bypasses what's called first pass metabolism. So when you take, for example, a pill, you ingest it, it gets metabolized by your liver and then excreted by your kidney and then goes throughout the bloodstream. Well, when we have skin formulations, it bypasses all of that. And so generally the risks are lower. Some women don't find the transdermal approach very convenient, so they would prefer to take an oral tablet. And this is the discussion, shared decision making that you need to have with your physician regarding the risks and the benefits of treatment. But if symptoms are affecting your quality of life, this is what we recommend. There's also a vaginal ring that you can place, that silicone one that I was mentioning, and it gets placed every 3 months. Now, again, remember, if you're on estrogen treatment and you still have a uterus, you need progesterone treatment. This can be taken in the form of an oral tablet or an IUD, which is an intrauterine device that gets inserted in the office into the uterus. And this will help protect against uterine cancer. So the risks, everybody, so why doesn't everybody get hormone therapy? This is why. There's an increasing risk in breast cancer, in stroke, blood clots in your legs or your lungs, gallbladder disease, as well as uterine cancer, which I talked about. The Women's Health Initiative was a study done back in the 80s, and it showed that there was a slight increased risk in breast cancer in the combined use of estrogen and progesterone for about 5 years. But relatively speaking, if your own health risk factors are low, again, this is a discussion that you need to have with your OBGYN, it is possible to take hormone therapy safely. So this graph shows the breast cancer risk overall. So it looks at the expected rates of breast cancer in women aged 50 to 59 over 5 years. So it looked at 1,000 women. So as a background risk, you can see in the middle, they saw that 23 out of 1,000 women had breast cancer. Now, if they were regular exercisers, they were meeting the American Health Association guidelines of 150 minutes. They actually decreased their breast cancer risk. So you can see only 16 out of 1,000 were diagnosed compared to the overall 23. But then look on the bottom. If you add in that they use birth control or combined hormone therapy, that's the orange, the risk was slightly higher. So it's 27 out of 1,000. Now look at the very bottom, a BMI of greater than 30. So this is obesity. Obesity triples the risk of breast cancer compared to the women who are either regular exercisers or even just normal weight. So these are the things that you need to look at for the future. So estrogen therapy also has other benefits. It can improve your sleep, your mood, and probably brain fog indirectly. And then again, it protects the bones. It decreases the risk for osteoporosis and fractures. Now, birth control pills are also actually an option, and it may be useful in some women that are going through the perimenopausal transition that are still having regular menstrual cycles, especially if they still need birth control, they don't want to get pregnant, and their cycles are very heavy and painful, and they're experiencing hot flushes and night sweats. I mentioned before that the average age of menopause is about 51. So about 90% of women will reach menopause by 55. So we generally will transition from the use of a birth control pill to hormone therapy if a woman is still having symptoms around about this age. And it's important to note the reason why we transition to hormone therapy is because a birth control pill has much higher dosing of estrogen. So again, as we get older, these risks are higher. So there are also non-hormonal treatments, and these are very useful for women who are not good candidates for hormone therapy, like they have breast cancer themselves, or there's a family history of stroke or blood clots. And these classes of medications are actually the antidepressant medications. They're the SSRIs. Now, this is considered an off-label use, but there is very good research and evidence to show that it improves symptoms, especially hot flushes, but also they are antidepressants, so they definitely will improve mood, depression, anxiety. Some women have come to me saying that they sleep better. So these medications are Paxil and Effexor. And again, dosages can be adjusted, but it's important to note that it does take time. I would say about 4 to 6 weeks for an improvement in symptoms. There's a new medication called Veozah. This affects the temperature regulatory center of the brain. Again, is a non-hormonal option. The only caveat for this is that you do need liver function testing every month for about the first 6 months because it can affect your liver enzymes. Supplements. Okay, so everybody always wants to know, should I use supplements? There are very few supplements that have very good evidence-based medicine. The term supplement itself is meant to be a dietary supplement, meaning you're not able to get enough through your diet. So for example, the most common is actually a prenatal vitamin, right? There's research to support its use because the average woman doesn't get enough folic acid in her diet, and it's needed for a healthy pregnancy to prevent spina bifida or neural tube defects. Another good example is like iron deficiency anemia. So it's very hard to get enough iron from your diet. So we may recommend that you use an iron supplement. But there's not that much research. And so this above list shows some of the most common supplements that can help during the menopause transition. But again, there may not be sufficient scientific evidence. So we have to take it with a grain of salt. I mentioned before skin and hair, so collagen and biotin supplements. Bone loss, certainly vitamin D can help, but calcium, you need to also just watch out because calcium can cause kidney stones. It can cause constipation. So unless you're vegan, you can get dietary calcium. Arthritic patients generally tend to use glucosamine and chondroitin sulfate for joint pain. Some people supplement omega-3 fatty acids for improvement in cholesterol. And there's some evidence to show that magnesium may help with prevention of headaches. So I want to talk a little bit about misinformation, and bioidentical hormone therapy is one of them. It is a marketing term which has been misused by compounding pharmacies to actually inaccurately label products as being natural or more safe without really any evidence that they are. Compounded means it's made in small batches, which is unregulated. So we can't actually know how much medication or how much estrogen or how much progesterone is in, for example, a pellet. These are not recommended. These products are not subject to FDA testing or research, and generally they're not covered by insurance. Many of the current FDA-approved treatments that I mentioned, the estrogen and progesterone that we use, are actually chemically identical to the hormones produced by the human body. So that is what we recommend. There's a massive market in selling courses and easy ways for people to make money, especially like nurse practitioners or even providers who did not learn about menopause. It's not just the certification that I got. You can go online and just take a course and then say that you're, menopause knowledge. So, but it's really important to note that every menopause society recommends against compounded hormone therapy unless there's a known allergy to some of the pharmaceutical medications that we recommend. Testosterone therapy is only indicated for low desire or low sex drive that is bothersome. Testosterone production doesn't really change much during menopause, but it does decrease with aging. And the reason also why we don't recommend it generally across the board is because treatment has side effects and they can actually be irreversible. So if you know that testosterone is majority of a male hormone. So if you take it in high doses, you can actually see unwanted hair growth, acne, and irreversible changes like deepening of your voice, clitoral enlargement if there's high doses. And these, again, can be seen in pellets that some of these like wellness companies are recommending. Okay, last thing about the misinformation piece, science versus snake oil. So be very mindful of what you're reading online. Make sure to fact check. There is a lot of misinformation out there, but there's also a lot of really good resources out there. ACOG is the American Congress of OBGYNs. Any Menopause Society, so the Canadian, the North American was now renamed to Menopause Society. Look for somebody who has these initials. That's the Menopause Society Certified Practitioner. This website is really great for just education and learning more about hormonal changes that occur during the menopause transition. And these books are just a few. The Menopause Manifesto. Actually, Dr. Jen Gunter is on social media. She's on Instagram. She also has a subscription that you can join online. She's in fact Canadian, so a little plug there. But she's very good. Her information is evidence-based, and she really breaks it down to the general public. So just choose your health professional carefully. Be sure, are they a physician who is board certified in their area of expertise? The wellness clinic that I talked about earlier is run by like a dermatologist or a plastic surgeon. And so a lot of this, again, is money making. Does that physician sell supplements? Do they have skin in the game? Or are they really looking out for the science? So in summary, many changes occur during and following the menopause transition. This is a crucial time for evaluating your health as well as preventing future health problems when possible. I want you to know that the symptoms of menopause are manageable. You can feel better as you go through this stage of your life. So please come and see your OBGYN for more information and for treatment if you are going through this currently. And lastly, just a little thank you. I wanted to show this picture. It's a little bit poetic because I wanted to take a generational picture with my daughter and my mom, and my son would not let me take this picture. You can see he has a little smirk on his face sitting on my lap. So just involve the men in your lives to become more health aware of what you're going through, what women go through, so that we can also help the next generation of partners. All right. Thank you so much.
Thank you so much. That was awesome. We have a lot of questions, Dr. Ladha. So I'm going to start with some of the confidential questions that I received. There's a Jamati member who had some IVF sessions and had a Mirena IUD placed, and
Okay.
OBGYN removed the Mirena as she was in menopause, but she continues to have hot flashes and brain fog and a lot of problems sleeping. Wondering if she should start HRT knowing that, she has a history of IVF. Does that have any correlation or any concern?
Yeah, really good question. So It's very common, for some practitioners to take out the Mirena because, again, a lot of us, we're using it for contraception purposes. And so if the average age of menopause is 51, 52, then we generally take it out because we want to see what your cycles will do if they end on their own. But if you do encounter having, the vasomotor symptoms, the hot flushes, the night sweats, and you are going to be going back on or on hormone therapy like estrogen, then like I mentioned, you need progesterone. So definitely an IUD is a great option because it's localized to the uterus. It gets inserted inside, and so it can really keep the lining thin. And that can then reduce the risk for uterine cancer. So that is definitely a great option for hormone therapy.
Great. There was another Jamaati member who's suffering from a lot of genitourinary symptoms and was on vaginal hormones for on and off for 20 years, but had a lot of yeast infections and UTIs. She's been suggested to have Botox in her vagina and bladder. Is that something that is offered?
So Botox is offered, but not for that indication. So I actually also treat a lot of women with prolapse and bladder issues. More so, she would probably need to see a urogynecologist if she's having issues with urinary incontinence, and that's where the indication is for Botox. So if the urethra has enlarged and a woman is having incontinence issues, then Botox is an option. But if her main issue is like vaginal dryness and recurrent urinary tract infections, I would definitely recommend vaginal estrogen specifically.
Yeah, she's been on it on and off for 20 years. So that's why this was the
So it
additional.
may be like, yeah, maybe different formulations. Like I'd have to sit down and sort of see like what kind of, did she use the cream only and then the tablet? And remember, I mentioned it does take time and it gets better, with regular use. So just sort of depends on like the formulation that she's used.
Great. Are there options for medications aside from HRT? I think you went through this, but what Jamaati member is asking is particularly for brain fog. You already talked about anxiety and depression. The SSRIs are good for that, but particularly for brain fog, are there any?
Yeah, so I mean, indirectly, the SSRIs can help with brain fog. But again, what I mentioned with the cognitive function is this is also something that's related to aging. And so really doing like activities that keep our brain sharp. But there's no medication out there that's indicated specifically to treat brain fog.
Great. For menopause-induced insulin resistance and cholesterol, you already mentioned that diet and activity changes are good, but is that enough, or do you think medication is likely needed regardless?
So that's going to be very individualistic. It's based on a woman's health factors, risk factors like family genetics. Is there a risk or a history of diabetes and heart disease in both parents? What is her current cholesterol? So that's really specific. Like I would have to do blood work. So when I do a menopause consultation with a new patient, for example, we go through the history, we go through what her main symptoms are, but also her family history, her current medical diagnoses, what current medication she's on. Sometimes I will do blood work with A1C screening for diabetes as well as cholesterol. And then ultimately it's shared decision making whether or not hormone therapy is a good treatment option.
Great. Um, Jamadi member has pelvic fibroids. In menopause, does the risk of, cancer in terms of without HRT, does that increase with the presence of fibroids?
So fibroids generally, they are just smooth muscle tumors in the uterus, and they are, for the most part, benign. When we go through menopause, because of the decreasing hormones of estrogen and progesterone, for the most part, fibroids actually decrease in size. They don't go away completely, but for the most part, they become smaller. And so they're usually not a concern unless they're so large that they're impacting like mass effects, like they're pushing on the bladder or they're pushing on the bowel. That's when we might indicate a need for surgery. but it usually doesn't impact menopause in the sense of like hormone therapy or increasing the risk of cancer.
Okay. And do symptoms of endometriosis decrease after menopause, or how does that change?
Yes, yeah, great question. Typically they do, yes, because remember endometriosis, there is implants that's supposed to be inside the uterus, but they're surrounding the pelvis and they cause pain with cycles and without cycles. And that's because estrogen and progesterone are feeding those tissue implants. And so again, once you go through menopause, the lack of or the ovaries stop producing the estrogen and the progesterone. So generally pain should improve.
And then I have another question which says, around a period, if you're approaching menopause or in the perimenopause period, is there a reason for headaches around the period, which you've never had, but
Yeah.
now it's increasing?
So some women actually have what's called menstrual migraines. And so they experience headaches or migraines just before the onset of bleeding. And that's because if you remember the up and the down of the cycle, that's because of the change in the hormone fluctuation. So you go from mostly estrogen and then that drastically drops and then you go to progesterone. And so if you cyclically have these headaches right before a cycle, that's because of the changes of hormones. And so because of that, again, relate that to menopause, that happens again, but it's that chaotic hormonal, fluctuation. So yes, that can happen during the menopause transition. And so along with if there's hot flushes or night sweats and things like that, when we do place women on treatment, they go from this chaotic, like hormonal roller coaster to getting like a steady state of estrogen and progesterone.
Okay, we're going to continue discussing some questions, but I just wanted to give the opportunity for people who want to leave. If they can just fill this survey, this will pop onto your screen now. We can continue discussing the questions, but I just wanted people to just fill this survey as it comes. So would really appreciate that. The next question I have is estradiol cream safe to use and for how long once a day with the tablets? But I think this will be very individualistic, but if you have any thoughts on that.
Yeah, so I had mentioned before, so vaginal estrogen is indicated for the genitourinary syndrome. And because it's very localized to the vagina, it is very safe. Initially, when I start patients on it, you use it daily just for 1 week. And then going forward, you use it about 2 to 3 times per week. And generally with the cream, it's messy, so use it at bedtime. And you use it going forward really for the rest of your life. It does not have the risks that oral estradiol or the patch have because it's very much localized to the vaginal tissue.
Got you. And again, very interesting question. I think very relevant also PCOS and menopause. So if you already have, some insulin resistance and high cholesterol due to PCOS and hypothyroid, does this get worse with the menopause?
So PCOS is very much an imbalance of the hormones. And so women tend to have a little bit more testosterone. And so you see like hair growth, we see polycystic ovaries. And it's just because of the imbalance between the estrogen, the progesterone, and the testosterone. And so these women generally tend to get on birth control if they're not trying to conceive. Through menopause, you may see, again, like it's the same sort of like imbalance or hormonal roller coaster. So as the transition happens, you may start to see some of these changes. But if you, again, get on sort of the menopause hormone therapy, that can help the fluctuations. If it's not as bothersome in terms of symptoms that you don't need treatment, then I would say you can, stay on the low dose birth control pills. But generally, as the ovaries shut down, you shouldn't see, a huge significant change in terms of that hair growth and that testosterone effect. The main thing would be looking at the risks, as I mentioned before, of diabetes, because women with PCOS are at higher risk of metabolic syndrome. So blood pressure, diabetes, heart disease. So really focusing in on diet and exercise.
Great.
In fact, women who if they have PCOS, if they're able to lose even 10% of their body weight, they can see their cycles come back to regularity.
Perfect. And someone's asking medication for the headaches, like you mentioned. I think you mentioned magnesium, but is there anything
Yeah,
else? Or
magnesium is a really good supplement. Yeah, so you can take 500 milligrams at bedtime every day. It can help prevent headaches.
yeah, there are many formulations. It's citrate oxide. I think
Right.
one of them causes some constipation. I think citrate is the most
Yeah,
glycinate or citrate is the most popular one, I believe.
right. Yep.
Let me just check if we've covered all questions. And again, please complete the feedback so that we can continue to get sessions which are great to the Jamaat. Um, I think everything is covered. Let me see. There was one more question.
Some of the chats.
Yes. So Jamati member is asking, I did ultrasound last year and this year, and it says same report, endometrial, stripe thickness is 0.7, which is abnormal is that abnormal in postmenopausal women?
Yeah, so good question. And so I guess twofold. What was the reason for sonograms? And we don't typically do like yearly sonograms or pelvic ultrasounds. So I'd have to take a look at the context of the findings. A 7 millimeter endometrial stripe is considered abnormal in a postmenopausal woman. We consider anything less than 4 millimeters to be normal. So if a woman has, vaginal bleeding after menopause, that is considered totally abnormal and has to be further evaluated. So anything greater than 4 millimeters requires a biopsy.
So yeah, this was in the context of bleeding after menopause, and the
Okay.
OBGYN gave the Jamati member progesterone tablets for this.
Without a biopsy?
Looks like without a biopsy, yeah.
Yeah, I would highly recommend getting a biopsy. There needs to be evaluation before we give any form of treatment to know why that bleeding is happening. Now, I think I forgot to mention that when we do place women on menopause hormone therapy, estrogen and progesterone, it is common to have some irregular bleeding for about 3 to 6 months as you start the treatment. But in this case, like if the woman was not on hormone therapy and she, all of a sudden spontaneously had postmenopausal bleeding, that is not normal. That needs to be evaluated.
Okay. And if you can just go back to that slide for the genitourinary symptoms,
Sure.
Vaseline and everything, because I think someone's asking any cream recommendation for itching. And I think that slide was great to just give an overview of what exactly one. Yeah, this one. So coconut oil,
Yep.
Vaseline, Aquaphor, multiple. Okay. I don't see any other questions. Does anyone have any other questions? Oh, one more just came in. Is long-term use of nystatin dangerous for vaginal itching?
Yeah, nystatin is an anti-yeast medication. So, I mean, you can certainly use it, but I wouldn't say long-term use is needed. Usually, a yeast infection should be cleared up after treatment, and then you stop using it.
Great. And another suggestion, please fill out the menopause session feedback form that's popping up on your screen right now. That would really help us. Um, I think that's about it. Thank
Can
you,
I,
Dr.
can I ask a question?
Yes, please. Yes.
I'm 54 and I still end up getting periods. I was just wondering when would they kind of end, or because
Yeah,
still getting them on regular basis.
so I had
No.
mentioned in that graph, right? So let me see if I can look back here. So the average age of menopause is 51, but on the upper limit, it can take sometimes 55. So between here, this graph says 45 to 57. So 55 to 57 is the upper limit of normal for menopause. And so sometimes we do also further evaluate, maybe do a biopsy just to make sure that everything is normal. It's likely that it's fine, but you're just on the upper end of the normal age.
Thank you.
You're welcome.
Great. And for those who missed this session or missed part of the session, we will be posting it on the AKHB website in the next week or so. Also, there'll be a YouTube link available, and we'll also email everyone when it's available. So that would be helpful. Please feel free to unmute yourself to ask any other questions before we adjourn. Lots of thank yous coming in. Just would like to share 100% of people answered that the session met their expectations. So that speaks a lot. Thank you, Dr. Ladha.
Awesome. Well, I'm really happy. I was very much looking forward to this talk. And so I'm really glad to see so many people. And like I said, feel free to message, but definitely, lots of things to do in terms of overall improving your health between diet and exercise, but following up with your GYN annually.
Yes, definitely. Primary care follow-up, OBGYN follow-up, definitely needed. Yeah. Thank you so much, Dr. Ladha, for this wonderful session. We appreciate this a lot.
My pleasure.
And
Thank you.
everyone, take care. Thank you.
Okay. Yali Madad.